I want to talk to you a little bit about coagulation or clotting, the concept that we covered in week 5, just to review a little, with some highlights of important points. Um, so, as we talked about, a consistent supply of blood is necessary for all cells. When we have injury that occurs to veins or arteries, then the clotting process is initiated to stop blood loss. It's an important protective mechanism that helps the body maintain homeostasis when injury occurs. If we didn't have this clotting process, we would all bleed to death, and that would be the end of that. As nurses, we should be able to promote healthy behaviors that optimize clotting, identify those patients that are at risk for impaired clotting, and then um, also recognize when they're experiencing impaired clotting and respond with appropriate interventions. That was a repeat, sorry. So as far as clotting is defined as that physiological process in which blood is converted from a liquid to a semi-solid gel. Process usually starts when a vein or an artery is injured. Multiple coagulation factors come into play in a sequence with fibrin and platelets to form a blood clot. So injury, again, we said is the initiator. We need to maintain that homeostasis so we can avoid the bleeding. We do need perfusion through sufficient cardiac output and that optimal chemical state that we've been speaking of. We call this the clotting cascade, and there are hundreds of clotting factors that are involved within this cascade, so it can get very hairy and deep. But problems with coagulation include insufficient clotting or excessive clotting, so too little or too much. Insufficient clotting, as you know, leads to excessive bleeding, whereas excessive clotting leads to blood clot formation, and then that obstructs blood flow or affects perfusion, that other concept that we talk about. Risk factors. Of course, no one is immune to coagulation disorders. Age, gender, race, socioeconomic has no role in this. Some people certainly are more at risk than others, such as older adults, because as we age, we have increased platelet adhesiveness, which results in blood stasis. If you remember, when we have blood stasis, our blood is not flowing as well, and that leads to clot formation. Genetics can play a role in conditions like hemophilia. Immobility, we talk about this all the time. This leads to blood stasis and clots, conditions that directly related to immobility is paralysis, altered mental status or an unconscious state, patients on bed rest just trying to heal, um, long flights where we're staying in one position for a long period of time. So all of those things have to be carefully assessed when you're obtaining histories from individuals. Someone accesses the healthcare system, they've got a DVT. Well, why do they get that DVT? You've got to know. So you have to dig into their history and start interrogating them about their activities of recent, medications they take, and things like that. But we'll talk about that just a little bit more in a few minutes. Smoking. Smoking is just bad. We talked about smoking causing vasoconstriction, so it decreases the diameter of our vessels. It also causes hypercoagulability, so it makes our blood coagulate quicker. And also, it damages the endothelial lining of our vessels. So it just doesn't serve us any good purposes and really increases the risk for clotting disorders. Medications such as estrogen, anticoagulants, and aspirin. So are your patients taking aspirin? Do they take birth control pills? Are they on Coumadin at home? All of those things have to be identified and assessed. So when we talk about bleeding, some things that can some of those causative factors of bleeding, such as thrombocytopenia, where we have a poor platelet count. And then you may think to yourself, you should take that a step further and think, well, what would cause thrombocytopenia? So something like leukemia, where the bone marrow is affected. Also, chemotherapy and radiation therapy can be precursors to thrombocytopenia. When we talk about genetic causes, we are talking about hemophilia. Hemophilia is that in which there's a clotting factor absent, missing, or drastically reduced clotting factor along that clotting cascade that leads to bleeding in individuals. When we think about clotting, we talked about polycythemia, where we have an increased number of red blood cells production, which increases the viscosity or thickness of the blood. We talked about that hematocrit being over 55%. What can do this? Well, you have to think about chronic hypoxia, the body's attempt over a long period of time to oxygenate through increasing production of red blood cells. And then increased erythropoietin, which increases production of red blood cells. Atrial fibrillation is another very common clotting disorder because the flow is interrupted through the atria, so there's more stasis of blood flow to allow for clot formation. We throw those clots. The most common complication of atrial fibrillation is a stroke, or CVA, or a brain attack, whatever we're calling it these days. So some of the pathophysiological processes of excessive clotting and thrombus, we have both arterial thrombosis, venous thrombosis, and then there's some pathophysiological processes that can cause clotting and bleeding disorders. So when we think of arterial thrombus, we talk about conditions that increase platelet counts or red blood cell production, and as a result, there's turbulent blood flow with platelet adhesion. Atherosclerosis is a big source of thrombi formation. Hypertension also damages lining of vessels from increased pressure, and actually can create a shearing force. And once you get that shearing force, where the plaque is broken away from the walls of the vessels, then platelets begin to adhere to those sites. Cigarette smoking can strongly promote arterial thrombosis, and other endogenous agents such as cholesterol. So when an artery is blocked, it interrupts the oxygenated blood to the tissue, right? Because arteries carry the oxygenated blood from the heart to your tissues, which leads to ischemia. And we talked about that. Continuation of that would lead to necrosis or cellular death. The location creates that pathological consequence. So coronary arteries, right? Myocardium, the cerebral arteries, the vein, the femoral arteries, the lower extremities, and then the size of that artery. So the larger the artery, the larger amount of area that's affected. When we're talking about venous thrombosis or veins, they're usually associated with inflammation. We talked about thrombophlebitis is usually associated with clot formation. These can be superficial or deep. Venous thrombosis are a hypercoagulability of the blood and vessel injury, the wall, the endothelium. And then coupled with that, we get the stasis of blood flow and the thrombus formation. And so we talk a little about Virchow's triangle, and it's these three things in venous thrombosis. So Virchow's triangle consists of first hypercoagulability of the blood, second injury of the vessel wall, endothelium, and third stasis of blood flow, and that's in a venous thrombosis. A thrombus that detaches becomes an embolus. because it moves. An embolus is something that travels from one site to another site. And so these venous thrombosis can travel and lodge into pulmonary vessels, creating the pulmonary embolus, and then you have a very emergent situation. Some disorders that cause bleeding include thrombocytopenia, liver diseases. Liver disease, cirrhosis impairs the liver synthesis of clotting factors, so those patients are more at risk for bleeding. The hemophilias, von Willebrand's disease, and actually von Willebrand is one of the clotting factors, so that is just a lack of the von Willebrand clotting factor. So we talked in class quite a bit about what it looks like if your platelet count drops low enough and you have spontaneous bleeding. We talked about petechiae, ecchymosis, nosebleeds, bleeding gums, on and on and on. So make sure that you review that. When we talk about assessment, we talk about history and physical and management of diagnostics and management of these individuals. So we start with our medical history. We want current and past. We want to know about chronic diseases, right? We want to know if there's any liver disease. We just talked about how the liver plays an important role in the clotting process. So you need to know if that patient has underlying liver disease. So medications that the patient's taking, aspirin, Coumadin, any of those things are going to add antiplatelet effects. Remember that Coumadin prevents blood clotting by interfering with 4 vitamin K dependent clotting factors. This is why we have to be concerned about the patient's vitamin K intake while on Coumadin, and also know that vitamin K is the antidote for Coumadin should we need to reverse those causes. Some other things we'd want to look at, bone marrow depression, DIC, the hemophilias, leukemias, polycythemia, if they've ever had a history of that, any history of clotting things like DVTs or PEs in the past are important to note. Also, ask questions about their lifestyle. What are their exercise habits? How often do they exercise? What kind of exercise? It's important to know the length of time because, as you know, exercise increases blood flow. Do they smoke? Remember nicotine and its effects. So we want to certainly curtail those behaviors if we can. As far as bleeding problems, adults may report bleeding from gums when they brush their teeth. They may have bleeding from their rectum after they defecate or even after minor traumas. They may report fatigue or dyspnea from anemia if they have blood loss. Women should be asked if the amount of blood during menses has increased. Patients with prolonged bleeding could report blood loss from anywhere in the body, including nosebleeds, new bruises, black tarry stools, blood in their emesis, sputum, or urine, or even bleeding from their mouth. If we're concerned about an intracranial bleed, then they may complain of those neurological symptoms like changes in vision, a headache, sudden difficulty talking, or weakness of an arm or leg. In children with hemophilia, parents may be reporting minor bleeding after minor traumas. Let me say that right. Such a circumcision may be the first time it's actually detected that the patient has a tendency to bleed. Maybe it's after they lose a tooth or they have a little fall. And then bleeding into a joint, we call that hemarthrosis, can produce pains of stiffness and tingling, aches in the knees, the elbows, and the ankles. And so those are typical hemophilia complaints. Hematuria is also can be a complaint of hemophilia. Clotting, symptoms associated with a thrombus we've covered, depends on where it is. If it's venous and it impairs venous return, it also creates an inflammatory response. Sorry, I lost my place there for a second. So veins, clotting and veins frequently develop in the lower extremities. It impairs perfusion, leading to pain, redness, and edema. It will also increase the circumference of that affected extremity. So a nice nursing intervention for DVT may be to measure the circumference of the patient's calf, if that's indicated if the patient has a DVT. We talked about them becoming dislodged and turning into emboli and flowing superiorly into the inferior vena cava and lodging in pulmonary capillaries. The classic triad for a pulmonary embolism is dyspnea, chest pain, and hemoptysis. That chest pain is pleuritic in nature, it is sharp, and it is stabbing. And then, as mentioned previously, arterial thrombus in lower extremities too impairs perfusion. So we talked about the P's in class, the 5 P's, 6 P's, so it's escaping me, but pain, paresthesia, pulselessness, pallor, and poikilothermia, which is actually cool skin temperature over the actual affected area. So those were the P's. So on physical exam, make sure that you're addressing signs and symptoms of excessive bleeding or excessive clotting. Then we move on into diagnostics for coagulation. We touched on most of these in class, but a quick summary. We have a prothrombin time, which is a PT. We know that that's what we help. That is what helps us monitor the therapeutic ranges of anticoagulants. Coumadin is the PT. The INR is used to monitor the effectiveness of anticoagulant therapy, Coumadin. So that is given, of course, Coumadin is given to inhibit the formation of blood clots, so we need those therapeutic levels to be right where we discussed between 2 and 3 for the INR. And remember, the PT was 1.5 to 2.5 times the normal. PTT for your heparin, it measures intrinsic and common pathways. Without getting too much in there, just know that that's for heparin. Again, protamine sulfate, that's the antidote. And if the patient is on heparin, then we like the value to be, again, 1.5 to 2.5 times the normal, their baseline value. Fibrinogen is a clotting factor that can be measured. We don't do a lot of that. Platelet counts, we talked about thrombocytopenia already. We covered those values in class. So review the value for when we consider somebody thrombocytopenic and when they may have spontaneous bleeding. D-dimer we didn't talk so much about. It centers around thrombin and its ability to form clots and break down clots. The D-dimer is a very specific measurement, and it can be very specific to confirm a diagnosis of pulmonary embolism, so D-dimer and pulmonary embolism, and also it can confirm a diagnosis of DIC, or disseminated intravascular coagulation. And then we have our typicals on our CBC. We have obviously our red blood cell count, our hemoglobin, and our hematocrit. We may examine the bone marrow to assess for hyper or hypoproduction of platelets, our red blood cells. Again, polycythemia or thrombocytopenia. So polycythemia is too many red blood cells. Thrombocytopenia is too little platelets, and bone marrow production, hyper or hypo, can affect both of those cells. There's radiologic studies to consider, so that we have non-invasive venous studies like an ultrasound. We love that for venous thrombosis, such as in DVT, arterial and venogram. So both of those um, utilize radiopaque contrast to be injected so we can get the exact location and extent of occlusion. And dilation can be identified. So those are invasive procedures. They require informed consent, and patients must be asked about allergies surrounding iodine or IV dye, seafood. All of those things would raise a flag to a potential allergic reaction there, and maybe even cancel that test, just depending on risk-benefit ratio. So if we're going to save a limb, it may be worth the risk to have the procedure based on what the actual response was to IV dye in the past. On to clinical management. So health promotion and management of emerging and present conditions that compromise clotting. Healthy People 2020 has goals for bleeding and clotting. Not so concerned about you knowing that, but just understand that they have about 6 goals. So primary prevention is measures to promote health and prevent disease. Genetic counseling can be advised for couples who have a family history and want to start a family. Certainly, they need to be able to comprehend some medical facts, understand risk and options, and make informed decisions once they have the outcome of that genetic testing. Primary prevention measures relate to prevention of blood clots. So what strategies do we have for prevention that include the minimizing risk for blood stasis, increased blood viscosity, and vessel injury? Vessel injury, right? Smoking. Smoking's a big one there. So that's a strategy. Smoking cessation. Um, Leg exercises and prevention of blood stasis. Regular walking. Compression stockings. High-risk patients, such as those post-op ortho patients, are at highest risk for thrombus and embolus formation. So it's so important in your orthopedic patients to really be diligent about assessing them for this. So they will be given anticoagulant therapy just as a prophylactic measure. For those patients taking birth control, they need to be identified as at increased risk. Patients about teaching them about smoking cessation, we covered that. And then adequate hydration. That will decrease blood viscosity. Those are all important things to teach individuals, especially your older adults. And then secondary prevention includes screening and early diagnosis and prompt treatment. So there really are no routine screening tests indicated for the general public for coagulation. But how can we prevent bleeding? Well, we have to manage. Prevention and control of bleeding are cornerstones for individuals with bleeding disorders. These individuals, established individuals, they need to be able to recognize signs and symptoms of bleeding and when to know when to call their doctor. Their risk for trauma needs to be minimized, so safety, helmets and seat belts and things like that need to be reinforced. If they're taking anticoagulants, they should avoid taking drugs that contribute to bleeding, such as aspirin. They should avoid situations that can cause injury. Contact sports is one of those things. And some doctors will just flat out tell patients, no, you can't play football, or no, you can't wrestle. So those types of contact sports. Soft bristle toothbrushes, we talked about that in class. Electric razors. Avoid, avoid blowing your nose forcefully. That can initiate a nosebleed. You should avoid getting tattoos and piercings. Uh-oh, a lot of us are going to be in trouble, right? Women who are menstruating should count the number of pads or tampons they use and notify their provider if that number increases. They also may, if they have an established bleeding disorder, they should contact their providers before they have invasive dental procedures, teeth cleaning, even manicures and pedicures can be place them at risk for bleeding if they're hemophiliac. We should avoid medications by injection if possible. If not possible, get the smallest size needle that you can. Nurses are responsible for monitoring those laboratory tests, their PT, PTT, and INR. So all of those things help us manage people with established bleeding disorders and prevent bleeding in those. If they're actively bleeding, our obvious goal is to control the hemorrhage. So direct pressure over bleeding sites if able. Topical agents, we have some things that we utilize, gel foam or fibrin foam. Gel foam is a little dressing, it's spongy dressing, you cut it off, you put it on a wound, it kind of becomes a part of the wound. And you can leave that on for about 7 days. It's actually quite an amazing material. Ice application helps vasoconstrict for topical bleeding or bleeding in a joint space. And then pharmacological agents we'll talk about here. And supportive care, volume replacement, oxygen if you need to, if bleeding is that severe. As far as pharmacotherapy for bleeding, we can replace their clotting factors if they are hemophiliac. We can also give them platelet transfusions to increase the volume and improve their clotting. When we talk about pharmacotherapy associated with clotting, there are several groups, and we touched on most of these. Anticoagulants prevent the formation of blood clots. Those anticoagulants we speak of are Coumadin and heparin. Coumadin is the only oral anticoagulant available. And then we have low molecular weight heparin drugs such as enoxaparin, and another one is dalteparin, which is the brand name of that is Fragment, and you will see that. Antiplatelet agents, aspirin or Plavix. Clopidogrel is the generic for Plavix. Aspirin typically is listed as aspirin, but those are antiplatelet agents. Plavix is very common. Direct thrombin inhibitors, these drugs not as prominent. And then thrombolytic agents, the big clot busters that we use, the tenecteplase, the retiplase, TPA, which is plasminogen, tissue plasminogen activator, and streptokinase. Those are all thrombolytics. All of those agents have big risk of serious bleeding. So we really have to monitor patients. These are patients that go to the ICU to receive these IV medications. Invasive procedures that we can do to control bleeding or clotting problems or try to combat it. We talked about patients with polycythemia needing phlebotomy or removal of blood. So that's a common treatment for that disorder. Every 2 to 3 months in some patients, but certainly reducing their blood volume, their blood viscosity, and their bone marrow activity. Thrombectomy is the removal of thrombus from a vessel. And that's basically it. We can do it percutaneously or as an open procedure. And then filtering devices to prevent pulmonary embolism. There's a Greenfeld filter. For those that are at high risk or have had multiple PEs, they'll do that. Nutritional therapy, we covered this pretty much in class. We talked about vitamin K. Patients should keep their usual vitamin K intake consistent. So whatever their vitamin K intake is, it should be maintained. But they should be educated on vitamin K and sources of vitamin K, such as green leafy vegetables. Spinach and kale fall under that. Mayonnaise is high in vitamin K, canola oil, and soybean oil. Positioning is more critical than one would think in coagulation disorders. It affects our blood flow and our comfort. Patients with DVT, DVT, deep vein thrombosis, so it's a venous thrombosis, they're taught to elevate their legs. That facilitates venous return to the heart. We talked about this in class too. If the patients have arterial thrombus, they're taught to position their legs in a dependent position. So that way gravity can help improve perfusion to the feet, because we're interrupting oxygenated blood from reaching the tissues, and gravity will help increase flow and relieve some of that pain in those patients. Even after a brain attack, acute phase of brain attack, we elevate the heads of the beds of those patients because we want to prevent cerebral edema and keep increased intracranial pressure at a minimum. Other things that we do, we prevent pressure ulcers by repositioning patients so that we can maintain perfusion to dependent areas. If their patients are on bed rest, they wear SCDs or sequential compression devices. That also helps stimulate venous return to the heart. So that wraps up the concept of coagulation. Pretty simple. There are other interrelated concepts. You've already heard me mention perfusion. Obviously, with perfusion comes gas exchange, intracranial regulation, mobility, pain. All of those things are concepts that are interrelated.